Thank you for joining us today. I think this is the 7th webinar for this year, organized by Malaysian Association of Pediatric Dentistry. I would like to take this opportunity to thank all of you for your support, and we hope that every webinar session will benefit you. Before I start, I have a few announcements. To all participants, please remember to mute your microphone and switch off your video throughout this webinar. So if you have any question for the speaker, please type it in the chat box. I will read it at the end of this lecture, which is during the Q&A session. And we also will share a link for the certificate in the chat box 10 minutes before the session ends. All right, today we're going to have another interesting topic on dental trauma, which is specifically on avulsion, that will be discussed by our speaker for today. Let me introduce Dr. Thavamalar. Dr. Thavamalar Marimuthoo is a pediatric dental specialist at the Department of Pediatric Dentistry, Hospital Malacca. She graduated from University Malaya in 2005 with a Bachelor of Dental Surgery BDS degree, and she subsequently did her postgraduate training and obtained her doctorate in clinical dentistry, DClinDent, from University Kebangsaan Malaysia in 2014. She was an EXCO member for Malaysian Association of Pediatric Dentistry, and she is currently involved as a member in the committee revising the national guidelines in management of hypodontia. Her main research interest includes topic in supernumerary teeth and use of silver diamond fluoride in children. She also has interest in surgical cases, especially oral pathology and medicine cases among children. And also, she also has special interest in dental trauma among children. Without further ado, I would like to invite Dr. Mala to deliver her talk. Over to you, Doctor.
Good afternoon, all. Thank you, Dr. Nabila, for the intro, and thank you, MIPD, for the opportunity. Can you hear me?
Yes, it's good.
Okay, all right, thank you. So can I share my screen?
Yes, please.
Okay, can you see my slides?
Not at the moment.
Oh dear. Okay. Sorry, I'll try again.
Sure.
Can you see it?
Not yet.
Sorry, it doesn't.
Dr. Mala, did you share, did you open the presentation?
Yeah, I did. Yeah, I did. Hold on, huh? Sorry, unfortunately, my icon, the share one is not appearing.
You mean the share screen?
Yeah, the icon for the share, it doesn't want to click. Hold on, huh? Okay.
Is it okay now?
Yeah, is it okay?
Yes.
Okay.
Yes, cool.
Okay, is it okay?
Yep.
Okay.
Can see now.
Right, thank you. Sorry.
Alright.
Yeah. I'm still quite slow in catching up with this. Okay, my presentation today will be mainly on First of all, good afternoon to all. And my presentation today will be mainly on outcomes of and management of complications of replanted avulsed teeth. Okay, I will divide my presentation into 4 main parts. A little on intro. I won't be discussing on the management of avulsed teeth per se, as this talk was given last year under MAPD as well, based on the IADT guideline 2020. And secondly, I will discuss on the pathophysiology of avulsed tooth, what happens the moment tooth is avulsed, and then proceed with healing and adverse outcomes of replanted avulsed teeth. And then finally, take home messages. Okay, avulsion is defined as complete dislocation of a tooth from the alveolar bone and the soft tissue socket. In Malaysia, the common causative factors are MVA, falls, and hit by object. Falls are pretty common in young children, but in Western countries, spots would be one of the most common cause of avulsed teeth. Okay, it has been reported that survival rate of replanted avulsed permanent anterior tooth ranges from 70 to 83. So treatment of choice almost all the time is replantation, especially in children and adolescents. Why? Because it's to restore aesthetics and functions while maintaining alveolar bone contour, width, and height, except in cases where patient suffers from other severe injuries or it is the patient is medically compromised. Replantation will keep the future treatment option open, and also the tooth can always be extracted if needed and at the appropriate point following prompt interdisciplinary assessment. The goal of replantation in immature teeth is to promote pulp revascularization, which can lead to further root development. However, the risk of external infection-related root resorption should be weighed against the chances of revascularization, because such resorption is very rapid in children. And the positive thing about replantation is that when the tooth can always be extracted if needed and at appropriate point following prompt interdisciplinary assessment. In normal situation, the tooth is attached to the bone via PDL fibers, and when the tooth becomes avulsed, the PDL fibers are stretched and broken. The tooth displacement out of socket implies complete rupture of pulp neurovascular bundle at the apical foramen, which results in pulp blood supply interruption. Subsequently, there will be nutritional insufficiency and cell degeneration. Pulp will result in hypoxia and eventually necrosis. Meanwhile, most PDL cells become non-viable if an extra-alveolar dry time is about 30 minutes. Physiologically, the roots of undamaged teeth are protected against resorption by a tissue layer of unmineralized organic cementum, as you can see in your diagram. Okay. Depending on the severity of the traumatic defect, the number of PDL cells and the cementum's ability to regenerate reduces, and this layer may no longer act as a sufficient barrier between the dental hard tissue and the adjacent bone, thus no longer protecting the root from active clastic cells. Consequently, the PDL and the root structure will undergo bone remodeling processes and replaced partially or completely by bone. And if the PDL survives, the degree and timeliness of root resorption is improved and ankylosis is decreased. In favorable cases, the effect will appear more smaller only at the small areas of smaller demarcated areas, and the desorption usually will be limited for a period, leading to acceptable prognosis that lead to functional healing. But in more severe cases, the desorption may continue, especially if it's going to involve the whole root surface, and thus resulting in complete loss of root structure. If this final state is reached, incidental loss of the remaining tooth crown is to be accepted. This is known as replacement, whereby the tooth undergoes replacement desorption. Okay, when there is the presence of pathological stimuli, such as bacterial contamination or infection and the associated toxins, necrotic cell debris and mechanical stress, it may enhance the resorption process and then lead to rapid tooth loss in most cases. This is known as infection-related resorption. These cellular processes are also influenced by several other factors, such as individuals' medical and dental characteristics. For example, the child is diabetic, has periodontal problem, and also the quality on site primary management and sequential dental treatment. Therefore, it will affect the overall prognosis of the tooth survival. So, what are the outcomes of replantation after avulsion? Many studies have reported that after replantation of the tooth, the prognosis or outcome commonly remains uncertain. Healing complications are more common in teeth that have suffered trauma in supporting tissues and avulsion, especially if the tooth has complete root development. Healing complications can occur over weeks, months, or even several years after injury. That's why patient has to be followed up for a long term. Okay, so the outcomes of replantation after avulsion can be divided into 4. The best outcome we would like to have is pulpal healing, and especially in immature teeth. Okay? However, most of the tooth will end up with pulpal necrosis. Although it's a type of healing complication, and it allows functional healing if detected and managed immediately. The other 2 are the adverse types of healing complications, which are replacement desorption and infection-related desorption. Okay, replacement desorptions or infection-related desorptions are, as I've said earlier, are the probable adverse outcomes in comparison to the more favorable functional healing. The rate of ankylosis and desorption varies considerably and can be unpredictable. And as you can see in diagram A, there's a replacement desorption involving the whole root. Meanwhile, in the diagram B involves infection-related desorption, when there is also some bone loss. Okay, studies have shown that there are many factors that affects the prognosis of replanted teeth, especially stage of root development, extra-alveolar time, timing of root canal treatment, and medium of storage are important prognostic factors for tooth survival after replantation. Clinical evidence reports that systemic antibiotic therapy, splinting time, and concomitant crown fractures are non-significant into pulpal healing. Dry storage in contrast of milk, as well as immature roots and younger patient ages at trauma, increases the risk of tooth loss after replantation. Besides that, other factors that affect the prognosis of survival of replanted teeth are patient's compliance with follow-up visits and home care. Both parents and patient has to be advised regarding home care to the injured tooth, and as the teeth need optimal time for healing and prevent further injuries, especially patients in class 2 1 malocclusion, where they are prone to having injury to the front teeth after a fall, and advise them to have meticulous oral hygiene And rinsing with antibacterial agents such as alcohol-free chlorhexidine gluconate for 1 to 2 weeks is important. In a young child, it's desirable to apply chlorhexidine to the affected area with cotton swab. Okay, next I will discuss on the outcomes on pulpal healing in detail. The pulpal healing rates after replantation of immature permanent teeth ranges from 7 to 41. However, in permanent, in fully matured teeth, most of the time they develop pulpal necrosis. The healing process starts immediately after replantation and aims to establish end-to-end anastomosis in the pulp periodontium interface, and thus to guarantee blood flow to the ischemic pulp. When such anastomosis happens, usually it happens only in immediate replantation before the pulp becomes infected during this ischemic state, and before there's a presence of bacteria, and if not, it will cause errors in pulp revascularization, thus lead to pulp necrosis. There are two distinct radiographic healing patterns described. There is a pulpal healing. The first would be hard tissue deposition on the dentinal walls, followed by narrowing of the pulp lumen, as you can see in the diagram. Tooth 1 with open apex actually becomes achieves the complete root development, and there is narrowing of the pulp lumen. However, if this progresses, there are cases where it will lead to pulp canal obliteration. The second pattern would be hard tissue forms in the pulp lumen and is separated from the dentinal wall, and it's in continuity with the periapical bone with the arrested root development. It's more like the bone growing into the pulp, and you don't see the root thickening. Okay. All right. Topical treatment of the root surface with doxycycline before replantation has been reported to significantly increase the frequency of complete pulp revascularization by decreasing the frequency of microorganism in the pulpal lumen. That's been reported by Schweck in 1990. The systemic treatment with doxycycline, however, have failed to prevent or eliminate the contamination of the necrotic pulp, but it is said that it can promote periodontal healing. If spontaneous revascularization does not occur, then epexification or pulp revitalization or revascularization or root canal treatment should be initiated as soon as the pulp necrosis and infection is identified in this immature teeth. I'd like to share an article by Amaro and Santos et al. On pulpal healing in immature replanted permanent teeth. They said that pulpal healing was a rare event after replantation of young permanent teeth associated with extra-alveolar period less than 15 minutes. Furthermore, advanced root development stages were a strong predictor of pulp necrosis with infection in replanted immature teeth. Next, we'll talk on the pulpal necrosis. All avulsed tooth with complete root formation undergo pulpal necrosis. That's why IADT guideline actually promotes commencement of RCT within 2 weeks of replantation. However, Henderson in 2007 reported that pulp regeneration can be observed in avulsed teeth with incomplete root development when there's no diagnosis of healing complication at 3 and 6 months. But many studies that showed pulpal healing were done in animal. However, studies also have shown that the prevalence of pulp necrosis ranges from 17 to 100% for dislocated teeth, regardless of root stage. So what do we do? Is to do the treatment would be root canal treatment within the 2 weeks of post-replantation. In mature teeth is mandatory. In immature teeth, then the choice of treatment is either epexification, pulp revascularization or root canal treatment as soon as the pulp necrosis and infection is identified. Prompt treatment actually allows functional healing. So as you can see, this is a child, I think if I'm not mistaken, age of 8, presented with a VAS 1-1. This then, after some time, it was noted there was sinus at labial of 1-2 with the gutta percha. When we used the gutta percha, it was leading to the tooth 1-1. So what was the treatment done was revascularization was opted for the 1-1, looking at a very immature tooth with thin dentines root. So over the time, I think about 8 months post-op, we noticed that there was some continuation of hard tissue forming at the apical root. We're not sure if it could be the what type of hard tissue, we are not sure of unless we actually do a HPE or something. So, but we saw some thickening of the root at the apical end. And sorry. Okay, that was the clinical picture 8 months after revascularization. Probably you can see slight discoloration, but not very obvious though. However, the incisal age seemed to be at the same level and the gingival margin seems to be at the same level. Currently, the child is about 11 years old. Okay. The next would be infection-related root resorption. It was previously known as inflammatory root resorption. It's one of the most severe healing complication, which then, because it progressed rapidly and always associated with pulp necrosis and infection. It can lead to loss of affected tooth and evidence of root or bone desorption anywhere around the circumference of the root should be interpreted as infection-related desorption. And most of the time is prevalent after 3 months after avulsion, reimplantation. The treatment or prevention of infected-related resorption would be early pulp extirpation of replanted mature valves permanent anterior teeth. As suggested by IADT guideline, it should be commenced within the 2 weeks after replantation. The earlier would be the better. Immediate root canal treatment in immature teeth if there is a clinical or radiographical sign and symptoms of pulpal necrosis. It is suggested placement of antibiotic corticosteroid such as Ledemix or odontopase, followed by non-setting calcium hydroxide, would help in resolving the inflammatory root resorption. Placement of intracanal medicament containing antibiotic corticosteroid paced over 6 weeks immediately or shortly after replantation has been proposed to reduce root resorption. As you can see in an article by Panzarini in 2012, they have stated that calcium hydroxide remains the usual recommended choice as an intracanal medicament in replanted teeth. Although there's evidence to support initial use of corticosteroid antibiotic combination such as Ledemix paste to control potential early resorption prior to introduction calcium hydroxide, where there's however where the beneficial effect in the treatment of progressive root resorption has well proven. Okay, in an article by Soros et al. In 2014, they mentioned that healing complication occurred more frequently within the first 3 months, and necrotic pulp is the most common complication. Majority of traumatic dental injuries are associated with infection-related resorption usually involves injury to the support tissue and also avulsion. Inflammatory resorption was the most prevalent after 3 months, mainly in luxated and avulsed teeth. As you can see, when they did a study comparison over some time, at the 3-month, the healing complication at 3 months showed that in a vast tooth, almost all the tooth had a healing complication, 100% in complete root formation. Meanwhile, in incomplete root formation, about 53.6% had healing complication. That it would be at 3 months. And at the end of the 12 months, they found that all the tooth had actually suffered, all the vast tooth actually suffered healing complications. So healing complication is almost inevitable in a tooth which has undergone avulsion. And yep. Okay. Next would be replacement desorption, which is rather common complication after avulsion. Ankylosis is a common complication, as I've said, after avulsion, as well as intrusion, whereby the alveolar bone fuses to the root substance. When an ankylosed root is continuously resorbed and replaced by bone, it's known as replacement desorption. This condition is rather progressive, and eventually the entire root is resorbed. However, the rate of resorption varies with age. It's quite rapid in young children, especially when diagnosed before the age of 10. In a growing child, it causes failure of eruption, resulting in infraocclusion. If ankylosis is diagnosed before the age of 10 or before the growth spurts, the tooth is at high risk of becoming infraoccluded. If ankylosis develops during the growth spurts, then infraposition might be minor or stable. So this ankylosis actually disrupts the local growth, alveolar growth development, and thus result in space loss caused by the tilting of the adjacent teeth and eventually poor aesthetics. To date, there are no means of arresting or reversing the process. If no other changes intervene, the patient can retain the ankylosed teeth until the crown fall off or is removed by forceps. Tooth with replacement resorption at localized area have chance of being retained for longer period of time. As such, you can see in this diagram where there's localized replacement resorptions, and this allows functional healing. Infraocclusion is treatment for it will be in adolescent and children. It will be decoronation, followed by resin retained bridge, which is an removable partial denture or orthodontic space closure with or without composite resin modification or auto transplantation. Resin retained bridge, not very commonly used in children, but it can be advocated in adolescent with permanent teeth and stable occlusion. In young children, most commonly removable partial dentures are used. Auto transplantation usually done by using the premolar teeth, which are indicated for extractions if ortho treatment are indicated for these patients. Treatment decisions are based on full discussion with the patient or the child and parents, and the clinician's expertise with the aim to keep all options open until maturity is reached. And often interdisciplinary assessment also required. What is decoronation? It's a surgical technique whereby the crown and root filling are removed while maintaining the resorbing symmetric of new bone development. This will preserve the volume of the marginal alveolar ridge, creating a better condition for future prosthetic solution. When the growth is completed, then the patient can opt for implant treatment. If decoronation done timely, it preserves the alveolar width and rebuilds the Ross vertical bone of the alveolar ridge in growing into individuals. Anderson has suggested that age of decoronation is a very important factor. Being in boys, the average age would be about 14.6, while in girls it's about 13. You can see one of my patients whereby the tooth 1-1 was replanted after 12 hours and RCT was done on the 7th day. progressive replacement resorption has occurred, and there's a bit of infra-occlusion happening, as you can see the CEG level. This one's still a bit higher and compared to the 2-1. This child actually has a supernumerary tooth embedded inside. The coronation, of done, followed by composite build-up of the crown with fiber post bridge 2 years later. And 4 years later, when the PA was taken, there was a complete root resorption. But however, it was replaced by bone totally. And you could see good bone over there. Tooth loss is happens when there's a failure to replant or failure to thrive after replantation. So in these situations, alveolar ridge preservation are done to minimize the alveolar ridge atrophy to facilitate future implant placement. Various techniques or materials, whether it's alone or in combination, have been proposed for ARP, such as guided bone regeneration, socket fillers alone, such as bone morphogenic proteins, bone grafts, whether it's allograft or xenograft or autologous bone, socket fillers, growth factors. The reduction in ridge, width, and height following the different ARP techniques may be less than that which occurs following initial socket healing. However, ARP does not totally eliminate post-extraction alveolar ridge resorption or predictably promote new bone formation. Okay. And ARP is considered in situations whereby implant placement is significantly delayed after tooth extraction due to very young age, and there is a severe bone loss due to trauma or inflammatory resorption. The treatment options are space maintenance using removable or fixed prosthodontics, fixed denture prosthesis, tooth autotransplantation using premolars, implant prosthesis, orthodontic space closure, in combination with prosthesis, tooth autotransplantation or implant. All right. Okay, this is a case of a patient whereby there was a loss of bone height and width of the bone following tooth loss. He lost 2 teeth, I think canine and lateral incisor, and this was guided bone regeneration was done to increase the height and the width of the bone prior to orthodontic treatment because he's class 2. And so that it actually provides adequate bone thickness and height to eventually to fix a prosthesis. Okay, in summary, tooth replantation should be always the treatment of choice in young children. Although the long-term prognosis is highly variable and depends on range of factors related to tooth, such as stage of root development, extra-alveolar period, storage conditions, as well as those related to emergency or sequential treatment. The primary goal for rapid reimplantation is actually to preserve the periodontal ligament, inevitably the tooth itself. Almost all Walls tooth eventually will require root canal treatment. Follow-up is very important as complications can occur over long after dental trauma. It is as if you have unbound contract with this patient for a long term, and some patients you may end up seeing up to 16 years old. Parents of pediatric patients should be informed of the procedures, whether it's decoronation, autotransplantation, whatsoever, that might be necessary later if the replanted tooth suffers adverse complication. Always inform parents what is expected of them once we decided to replant and consequences if we don't. These are my references. Thank you so much. And before I end up, I would like to inform that our next webinar will be on pediatric dental management of hemophilia patients by Dr. Rosiana Abdullah. Thank you.
Thank you, Dr. Mala, for a very informative lecture. We have two questions here
Okay.
by Pitt's Dental Hospital Kajang team. Yeah. Thank you for a nice lecture. And they would like to know in what cases of avulsion that you recommend for obturation, and what cases just review and change non-cystic calcium hydroxide. If able to obturate, do you suggest normal obturation, which is using gutter Pulper or with MTA or biodentin? What do you think?
Okay. The first question, when do I obturate? Is it?
Yes.
Okay.
Obturate, and when you review or when you obturate?
Okay. If out of my personal experience, like if I don't see any changes over the root development, whether there is no any replacement resorptions or stabilized, if I don't see progressive replacement resorptions or there's no inflammatory resorption over a period of 3 to 6 months, then I will obturate. Most of my patients, I don't obturate immediately, although sometimes the guidelines say you can obturate within a month, but I don't, because removing it will be another issue, especially in young children. So I will monitor them about 9 to 12 months actually, to see if there's any, if you have seen my articles, some of the articles, they say complications can happen up to 1 year. So I will see if there's no progress in the complications such as replacement resorption is stabilized, or there's no replacement, inflammatory resorptions, then I will proceed with obturation. And my personal choice of material usually is gutta percha. I would prefer lateral condensation than the flowable ones, because the flowable ones you can't actually pull it out, and it's a bit more difficult to remove compared to the one you do with lateral condensation. I don't use this what do you call, resin based, no, because if at all there is a continuous resorption, it's quite difficult to remove this resin based type of fillers into the root canal. Other than that, I've actually tried zinc oxide, non-reinforced zinc oxide eugenol. In a couple of patients, it somehow worked, but there's not much evidence on usage of it for obturation. But these patients somehow seem to have the canals, the tooth stable there for about 3 to 4 years. I don't do MTA to fill up the whole tooth, especially if there is immature tooth, because removal would be difficult as well in case if I decided to do a decoronation. Yeah, does it answer the question?
All right. I hope this answers Pitt's Dental Hospital Kajang team. And there's another question by from Dr. Kugendran. Hi Kugen, how are you? Doctor, thank you for the informative sharing. What's your opinion on extraoral root canal treatment in cases where the extraoral dry time more than 60 minutes, mature tooth, as the latest guide don't recommend them? Would you still prefer intraoral root canal treatment?
Okay. I've always, I think I would prefer go for intraoral root canal treatment because of the complication that happens. Because if, I've done in a patient whereby the extraoral time was about 4 to 5 years while waiting, and I had to do the patient under GA. And that's the only time I actually obturated the canal extraorally, because the child was not cooperative for TNS, none at all. So I had to do the TNS under GA. And at the same time, we decided to reimplant the tooth, and knowing the patient's behavior such, we decided to obturate extraorally before implanting it. But then the tooth actually suffered replacement desorption quite fast. But I'm not sure whether it's because of this. But I would prefer to monitor, because I would prefer to do it intraorally, whereby after replantation, proceed with the root canal treatment, placement of antibiotic plus corticosteroid medicament, and then followed by calcium hydroxide, so that it will slow down the replacement or inflammatory resorption, and you can have the tooth much in the for functional purposes. That's my preference.
All right, I know it's a bit tricky when it comes to management of the avulsion.
Yes, there's no hard and fast rule. There's no hard and fast rule for each. It all depends what kind of patients you are seeing, how the patient's behavior, and this.
And there's many factors to consider in managing this kind of case. Actually, we have another question from Sirin Fong, Dr. Sirin Fong. Thank you, doctor, for the sharing. At what age usually can the patient who underwent decoronation can have bridge or implants done?
Oh, okay. As I think I've mentioned earlier, decoronation, actually we don't do it very early. I usually will see the clinical findings when the moment the infra-occlusion is about 1 millimeter, then I will proceed with decoronation. But it is suggested that for boys is about 14 years old and average age, and for girls about 13.6. But it all depends on the growth spurt. Okay, it is suggested that if the what do you call that ankylosis is diagnosed before the age of 10, then we should do the, and there is infra position after that, then you should do decoronation within 2 to 3 years after you diagnose them with infra position. Sorry, ankylosis. But if child is currently on has undergoing the growth spurt or already had the growth spurt, then you may not need to do a decoronation, because most of the time the infra position is not so severe. So as I've said, it all depends on each patient. You can't have like one way of treatment always for all the patient. Okay.
Yeah, I do agree. What do you think? Would you do decoronation in young age patient with a early sign of ankylosis? Like you said, I mean, during review we can see a high metallic sound, but there's no. I mean, clinically, there's no infra-occlusion. And also radiographically, there is no sign of replacement absorption. What do you think? Would you start decoronation if just early sign of ankylosis?
No. Actually, the decoronation is done when there is an infra-occlusion. And when there's infra-occlusion, severe infra-occlusion, and usually the clinical signs will be there's a tilting of the adjacent teeth, affecting the aesthetics. Okay, and if you can take a PA, you see that there's no bone growth. Another sign will be to see the labial gingiva of the ankylosed tooth. You see there's a fold. I will do only decoronation if there is a severe infra-occlusion, not for just for ankylosis. If there is a progressive ankylosis, I will keep it until the tooth is mobile. Only then I will remove it and then replace with a prosthesis. Otherwise, I don't do decoronation for all ankylosed tooth.
All right, that's great. There's another question from Dr. Shamimi Amalina. Hi, doctor. Instead of root canal treatment, can we do Schweck pulpotomy first? In future, if there is sign of infection, then only we do root canal treatment.
For which tooth you're talking about?
I think she's
Because
talking about the
I'm so sorry. Shrek
replanted.
pulpotomy is done when you suspect probably the pulp is still probably vital or is reversible pulpitis or something. When there's pulpal exposure, and only then I will do the Schweck pulpotomy. But in a vast tooth where the pulp has been necrosed, I don't do Schweck pulpotomy. If you can open and see if there's a pulp bleeding, then that would be a sign for you to do a Schweck pulpotomy.
Yeah.
So we need to be clear of the indications before we do any sort of root treatment. Basically, I think Schweck pulpotomy is not for advanced teeth.
All right. So there's another question from Dr. Sukin Lee. Dear doctor, thank you for your informative lecture. Just curious if replacement resorption occurs on a mature root canal treated tooth, what will happen to the gutter perca in the canal?
It will be just there until you remove it. Gutter perca will not dissolve.
Unsolved.
So yeah, so you will have it, and as the replacement resorption progresses, you will see that the bone is enclaving the gutter perca. So it will remain there as it is. Okay.
Yeah.
I've not encountered any situations where it has become infection and causing infection, but mostly it just remains there until the tooth becomes loose. And then at times I've noted that when you remove the tooth, the gutter perca comes out, but most of the time it doesn't. So you may have to go in and remove the gutter perca.
Yeah. Let's say you want to do decoronation, basically you need to remove it. Otherwise it will be there. Yeah. Okay, so there's another question from Dr. Farah Yusof. Hi doctor, thank you for the lecture. Can you explain more about cases of teeth with resorption for a limited period? I think it's talking about the transient apical breakdown. And what is the most favorable? Yeah, because she used the term here with resorption for a limited period. Yeah, so I assume it's a transient apical breakdown. And what is the most favorable management for the teeth? Do they by any chance we show any signs of perio problem, for example, mobility?
Transient apical, I think transient apical resorption is it. Usually doesn't occur in advanced teeth. You can see it happening in other luxative injury or probably crown fractures or subluxation. It can happen. Those kind of it's a bit out of topic, but anyway, I can tell. In the transient apical resorptions, you can actually monitor first for a while. If you find it's progressing, then you may, of course, class with your clinical signs and symptoms and whether it's responding to pulp sensibility or some test, then you can do root canal treatment, proceed with root canal treatment. But if you see that it's reversing, it's not progressing, then you can assume that it's vital still. The transient apical periodontitis is more of a short-term reaction to the injury that happened to the tooth, PDL tooth. Okay, so that's why you have to monitor them probably initially monthly. Then but it doesn't. If it's transient, it will resolve very fast. If you meant by the, I don't know if she meant by the localized resorption areas that happens in the root surface, I would monitor for about 3 to 6 months. If I don't see it's not progressing, then I will obturate the tooth.
All right. I hope Dr. Mala answers your question. Dr. Farah? Okay, there's another question. I'm not sure whether you have answered this question or not, but I'm not sure whether Dr. Serene Fong accidentally posted it again or you haven't answered the question. At what age can patient proceed with bridge or implant placement?
Of course, implant you have to wait for the child to stop growing. So it's more of an early adult phase, okay, when the child sees this growth. Breach, even also about the same. We don't do it, breach very early. What I do was probably a Maryland breach, where you don't actually cut the adjacent tooth. So Maryland bridge basically doesn't cause much disturbances to adjacent tooth. Of course, you need to have a stable occlusion. So, and the survival of Maryland bridge is not very long. It's about 1 to 2 years, if you ask me. So, it's based on the patient's requirement. Some are patients whom I will always start with partial denture first, and most of the boys will end up losing the dentures in the toilet, my patients now. So when I know that for 2 to 3 accounts that the denture is lost in the toilet, then patient is not compliant with the partial denture, I will opt for resin bridge. It's not so then if and based on their occlusion and stability of occlusion. In mixed dentition, I usually don't encourage placement of resin bridge because of the eruption of the teeth actually causes movement and it tends to fail faster. So it's always the partial denture for these children. If I'm not mistaken, Anderson have advocated lingual arch denture, but I've not done it. So most commonly is partial denture. Bridge would be at later age once they're adult. Permanent bridge.
All right. All right. Is it okay, Dr. Shireen? Does it answer your question? Okay, I think that's all for today, Dr. Mala. Thank you very much for sharing with us.
Okay.
I can see Dr. Sharina from my screen now. Hi, Dr. Sharina, orthodontist when I was in Pahang. Okay, so thank you so much for sharing your presentation with us today. Okay,
Okay.
so once again, I would like to thank all of you for your support, and I hope to
Okay.
see you during your next webinar. And just want to remind you that please, we have shared the link for the certificate. Okay, just click the link and fill the form, and we will send you the certificate. And the recorded version of this webinar will be uploaded in our YouTube channel. Okay, please visit our YouTube channel MAPD 2021, and you can freely watch the previous webinar if you wish to do so. Okay, I think that's all. Thank
Thank you,
you,
Dr. Nabiha.
everyone.
See
Yeah,
you.
have a nice day.